I just turned 20.
Who's the youngest one in the class, by the way?
I think it's
Maddie.
I know it's not Mark. It's you two?
I'm the youngest.
Are you 19?
I am.
Are you really?
Yeah.
Wow. Man, your retirement's gonna be amazing if you do
Yeah.
that. Sorry, I got into it when I was 21, and people it blows their mind. And I'm just like, oh yeah, I got 11 years and I can retire. And they're like, what? I'm just like, yeah, 11 years, I'm out. And they're like, no way. I'm just like, yeah, no, I don't think I can retire. But it's a good thought. Chiefs make me angry enough and be like, you know what, peace, I'm out. See ya. Got me. All right, so let's go back to this dude. So Chekhov was scrunched by his car up against a post, right? So what he died of, let's just present a little case, right? So obviously this is not him here, but this guy here and Chekhov, same injuries, okay? The 44-year-old Caucasian man working under the car when the vehicle's transmission system fell on his chest, squeezing his torso, doing the heavy item in the ground. Piece of cake, right? Yeah?
No.
Everything good?
Uh-uh.
Unknown time. He was found in an unconscious state. Oh, shit. Right? Not good. Called medical aid. It was estimated that at least 1 hour had elapsed before the patient received medical care.
So does that mean there was an unknown amount of time before the patient called them, and then 1 hour later they received care, or total time
Let's
from?
just say total time was an hour, just to simplify it. Okay? Total time is an hour. What are we thinking so far? Anything?
Are they still alive?
Carter syndrome.
I got some questions.
Oh.
Wondering how I'm gonna get the case off her chest.
Right there in front,
Under
right
the
there in
car.
front.
See, I like this. I got some questions.
Oh, jeez. I said that
You never say you got questions
I
and
said
then be
that a little
like,
too loud.
hurry up, faster, faster,
No,
faster. Fire them off. Speed. Let's go. Speed,
so,
speed, Go
Like
to
how
speed.
far did the transmission fall? Was it like on a lift or was it?
No, it's just like 5 feet.
5 feet?
Yeah.
That guy's probably dead by now. 5 foot fall from a transmission onto your torso?
Let's see. As
Transmissions are so heavy.
He was
Unconscious.
under the car.
He's in unconscious state. Does he say if he's alive or not?
No.
He's alive.
Does he have a pulse? Is he breathing?
Let's see if I got oh, there we go. Boom.
There we go.
A little bit of picture painted here.
Okay.
How many red flags do we see?
Lots.
Oh, man.
Decompensation.
8.
A lot.
A G's. We got a G's amount. Now. Okay, now what?
Yeah.
Faster, Cody. Faster. You're standing over the top of this person right now. Make a decision. What?
He's got a car on him.
No, it's just the transmission that fell on him.
No, he was under the car,
Right.
and the transmission fell out from inside the car onto his chest, so he's under a car with a transmission on him.
So you're saying that you've got
But it
all
fell
of his
5
vitals
feet.
and all of his assessment and all of this stuff while he's still under the car?
Probably took them out already.
I would hope
Right?
so.
Oh, way to be the thinking
That
paramedic.
would be my question.
Good job. All right,
He's
B.
still pinned.
B, guess what? You just earned the right to figure out what to do now.
RSI the person.
RSI.
Take out the well, you took
Why do you need
off
RSI?
RSI, controlled breathing.
Did you
Check
say a
if
bit?
there's any bleeding around.
Okay.
need to give him a
Would you not get ID access and give setting environment?
Yes.
Yes.
Give.
So as you're looking at this person, let's see if I got it. Is it the next one? Nope,
Because if he
Jesus.
was down there for at least.
Okay, so you pull your patient out, right? This is before you even pull them out. This is how they present. This is what they look like.
A
Before
Caucasian
you pull it out.
Hispanic fat guy's skinny.
Yeah, those are the same.
Oh, traumatic asphyxiation. Oh my gosh, I can't say it.
Asphyxiation.
Sorry, it just hit me. I was like, oh, that's that.
It's that.
Yeah.
Yeah, what's that?
It's where like all the blood gets trapped in your head and stuff, and then it's just traumatic asphyxiation. I just remembered what it was. That's all I had.
So say the term of what it is.
Oh God, but I can't say it right
That's
now.
why I'm having so much fun right now.
Asphyxiation. Traumatic.
Traumatic
Dustin?
asphyxiation.
No,
There we go.
I was
It
helping
nice
her.
though.
Wow. Wow. See if I ever help ever again.
I don't want you to get
I'm
faced,
gonna keep my
Dustin.
mouth shut
No,
now.
if you get faced.
Let's start.
Oh, wait, no, I gotta keep track what the order is.
Is that what we're staying late and early for to watch the pacing?
Yes, as a collective group. All right, so Michaela, what do you got?
Traumatic oh my god, I had it a second ago.
Not gonna help you again.
Asphyxia.
Yeah, I don't know why I can't say that right now.
What does asphyxia stand for? Somebody asphyxiates.
Suffocating.
Suffocating in which sense?
I didn't hear it.
Oh, there we go. All right.
Wow. Like
So
you, wow. Wow.
traumatic asphyxia. So basically, you shunted the entire body. You put a tourniquet on right here. All the blood gets trapped up here in the head. Venous system completely continues. So your heart's still pumping, right? But the blood has no ability to circulate. So all of your blood is staying right here. So your venous system backs up into the head, but it can't back up down because there's nowhere for it to go, right? So everything backs up here. You have increased interthoracic pressure. You have this increase in intravascular pressure, which then bursts virtually every blood vessel in the small blood vessel aspect from the injury site up, right? So not only does it, most of the time is, most of the time it is the face and up, so like hard blows to the chest can cause it, a partial entrapment where like somebody just runs, like, so if I was standing here like this and Cody ran and just drilled me right in the chest and just pinned me up against that, just that very short momentary increase in interthoracic pressure, and if he were to kind of lay into me a little bit and hold that for any split second in time, you don't, yeah, right? You can create that ability to burst those blood vessels as long as it's not a boom and you're away kind of thing, right? So you have to be able to hold that because you have to hold that pressure on those vessels long enough to burst them. Does that make sense? So you notice as people, the longer they have this event, the circulation continues, right? So circulation is continuing the longer they're pinned. You're going to end up with severe petechiae in the eyes. Petechiae above the site. The longer they've been there, the more purple they're going to be because there's more blood that is exiting the vessels out into the tissues.
What's petechiae?
First blood vessels in the eyes or little purple spots on the skin, like meningitis rashes are commonly called petechiae. It's pigmentation, like a purple pigmentation. Not even going to try and spell it for you.
It's like a crazy.
It's P-I-T-C-H-I-E-I-E-T-T-I-E-L-E.
There's L in it. Wow.
No.
Who knew?
It's legitimately like one of the hardest words in pre-hospital setting. Was it?
It is a PI.
There it is at the bottom.
There it is. P-E-T.
Oh.
Not even close, right? So, primary care for this person.
How would you prepare for this person?
Primary care.
Oh.
I know, I mumble a lot. Yeah.
So is this like compartment syndrome, but with respiratory compromise as well?
So there is the compartment syndrome potential for it. But think about your crush injury. What type of injury are you looking at with crush injuries? With your compartment syndromes, and why we're giving the sodium bicarb?
It's the
Because the
buildup
buildup
of
of
acid
acid, right?
below the site.
Are we going to have a buildup of acid in this situation? It's a little bit different. So there's it's a mixed review out there nationally on whether or not to treat this like a crush injury or to not. Like if you read a bunch of the journals, read a lot of the textbooks and stuff, some are advocating saying, yes, absolutely, this is a compartment syndrome crush injury, and you should give the sodium bicarb. Treat it just like that, right? Other people are saying, oh, you know, it's more of a change in intrathoracic pressure, a circulatory issue, and a blood vessel bursting kind of thing. And it's more of a vascular aspect versus the acidotic aspect, right? So they're not able to ventilate, they're not able to exchange the gases because the thoracic cavity is unable to expand because of the compression. So there's this big mixed bag of whether or not do we or don't we. So with that being said, I would say go with whatever your department says you can. So like us locally, we don't give bicarb for this kind of situation. Right?
My question is, if you have a 1 hour downtime in a patient like this, they're
gonna be acidotic.
They're gonna be acidotic anyway,
Right.
so what's the harm of getting sodium bicarbonate?
And that's what the argument is. Even if it's bad enough to put all this blood into this
It can't
portion
get out.
here, that blood is not oxygenating, right? Non-oxygenation equals acidosis. So that's my thought process and my argument behind the thing of, I would go the route of, this is a compartment syndrome, this is a crush injury, right? So it's just one of those things, like, there's no absolutes in pre-hospital setting a lot of times, and things are constantly changing. So just take that into thought and consideration as you guys are doing your paramedic assessments and stuff. So, we're gonna just say, either yay or nay, you went with the bicarb or you didn't, all right? Boom, out comes the person, you got these vital signs. Boom. Sick or not sick? Priorities.
Airway.
Oxygen, right? Is this person gonna without oxygen? Is this person gonna survive?
Maybe not, probably not.
It's grim.
Yes, they're gonna survive, at least in your ambulance, right?
Right.
Of course.
Yes, because they're alive now. The bad thing is if they're alive before you pull them out, what can potentially happen when you pull them out?
They die when you pull them out.
They die shortly after because of the mass influx of acid, right?
So, back to that, before you pull them out, you're gonna have
Yes.
a massive flux of
Right.
acid, why would you not try and mitigate that by getting an IV started before,
Right.
give them some sodium bicarb before you even pull them out of there?
Right. And so some of it's gonna be whether or not you can gain access,
Yeah.
without having the picture to give you, be like, hey, this is the exact scenario. It's where you were basically like, we're throwing darts at, hey, you could do this, hey, you could do this is what we need to think about. And this is exactly what you need to do as a paramedic. Take the scene, size it up, and then start making decisions. And be like, okay, before this person comes out, because we have the ability to gain access, I'm super excited for doing one of our scenarios that some of you guys have seen in the past. But this is an almost identical situation to a scenario that I give you guys. Access is virtually impossible, right? So you have to make certain judgment calls of, are we doing this? Are we gonna take this route? What route are we gonna take? And that's part of just being the paramedic and making decisions based on what you're presented with. So yes, bicarb is what I mean, the thought process, reasoning, as I think through it, I'm wanting to give bicarb to this person, right? And so you just have to have the scope and the ability to be able to say, yes, that's what we're doing,
And you want to give it before you move them.
before you move them.
Well, and it says in the protocol too, it says administer immediately prior to release of the trapped body part.
Right, the other thing is we're supposed to put tourniquets on. Hey, let's put a tourniquet right here, right? Put it right around the neck.
Yeah.
Yeah, you guys cool with that?
As long as there's a lemon in
Everybody in
there.
favor of a tourniquet? Aye? And Elise, good job, way to step up.
I have a question.
I'm sure you do.
What do you even care about access if they're not circulating anyway?
Like, can you get to them? Like, how long is it gonna take? Can you get somebody in there to do an IV? Can you do that?
If you get
I know,
ice-
but like,
The body's not circulating.
your body's not gonna circulate it effectively. So why do you even
'Cause they're
care?
Because right now, it's sitting on the chest,
Right,
okay? So right now, the circulation is not occurring.
right,
Are you gonna transport them to the hospital with that sitting on their chest?
no,
So you're gonna remove that, you're gonna remove the obstruction,
right,
and what's the body gonna do?
recirculate.
release
It's gonna
that
recirculate,
acid.
and it's gonna release everything that's here out into the body.
Right. But
So you wanna
pushing your
dilute it with
medication
fluids.
prior
Lots of fluids.
is not going to necessarily matter because medication is
Yep,
gonna
so-
sit in your lung.
Right, so the idea is you give the medication, right, they're trapped, right? Boom, it's right here, it's right on Dustin. He's trapped,
Yes.
right? We give the medication,
Right.
yeah, it's not circulating,
It
right?
goes nowhere.
But go ahead and read it one more time.
Immediately prior.
Immediately prior, right? I give the medication, off it comes, out we go.
blood circulates.
And you would do calcium.
Sodium
gluconate or
bicarb circulates.
Calcium chloride also for
Just bicarb.
hyperkalemia?
Nope, just bicarb. Does that make sense? So it's the immediate prior to, so it goes in, it's not circulating, you clear him, out he comes, it's circulating.
How does this affect IO? Because you go get IO
It may
access,
or may
it's
not
a lot
work.
easier than IV because your vein access are pretty limited because there's no circulating.
Yeah, there's
You do
nothing.
IO and you get a potential better circulation because you don't need flow of fluid for an IO.
Right. But you still need circulation.
I'm just thinking.
Because the
you
bone
use
marrow,
access,
and
it
the
almost
bone
like-
marrow, when you infuse the bone marrow, it still eventually ends up in the circulatory system.
Correct, I'm just thinking of ease of access though, it might
Right.
be easier just to get an IO.
Yeah, with
Yeah,
a
it's another
blood
thing to
pressure of
consider.
80/40 and all that fluid up in the upper cavity.
Yeah.
Flat, you're gonna have flat veins.
Flat veins.
Yep, you're gonna have flat veins, and so, yeah, a lot of it's gonna be, once again, can you get to an IO site? Can you, I mean,
And we can do humeral
Yep.
or.
yep, and there's a lot of places nationally that can do sternal, IOs.
But you've got the transmission.
Yeah.
Right.
Yeah, so
I
there's a
mean,
lot of
so-
things to
so-
consider.
So that's the thing, is like you have all these options, because that's the kind of thought processes you're gonna run through. You're like, oh, I got this option, I got this option, oh, no, we can't do that because of this, oh, I can't do that because of this. And that's what you're gonna do as a paramedic, is you're gonna think through your assessment and your reasoning on this stuff. Yeah? Yes, no, okay, move. All right, so, SIG, yes, agreed,
Million equivalent.
maybe? Okay. PTPI, boom, so primary, okay, yep, got that. Okay, so, our management with this patient, we're gonna get him out, we're gonna bicarb or not bicarb. What other additional things are we gonna look at? Sarah? What are you gonna be looking for with this type of patient? You already asked the question, do we give something?
So hyperkalemia,
Okay,
calcium,
and what do we give for hyperkalemia?
Calcium
calcium, gluconate, calcium
Okay,
chloride.
so we do not just automatically give our calcium in a crush injury, right? Because the patient isn't technically hyperkalemic yet, right? We're giving our bicarb for our acidosis, but what we do have to do is we have to watch out for a 5 or 10 minute person, right? So we're constantly reevaluating. This person's getting an EKG because we have chest wall issues, right? So you're watching the chest, you're watching the EKG, and we're looking for what?
Spike T waves.
Spike T waves are the primary thing that's going to cue us into whether or not this patient's becoming hyperkalemic as well. All right. And so we're watching for that. What else? What other kinds of things are we watching for?
Look for.
How about
Matter.
chest rise, lung sounds? Any damage to the lungs? Tension pneumos?
Clearly having a finger.
Pericarditis.
Anything in the
from here to here?
abdomen?
Yeah. Anything from here to here that could potentially kill them, right? Things that we can fix, like we just talked about tension pneumothoraxes.
Fill chest?
Additionally, what other kind of injuries? So we've talked last term, cardiac tamponade, right? And how do we assess for cardiac tamponade?
Vex triad?
Vex triad, was that Amanda?
Yeah.
With the whisper from the back row. Amanda, can you tell me what the Vex triad is? Faster?
Not fully.
Faster?
Muffled heart sounds, hyperresonance, and something else.
Pulse
Anybody else want to help out, Amanda?
Narrow pulse pressure.
Pulse pressure,
Pulse pressures.
Pulse pressure, muffled heart.
muffled heart, hyper.
Anything else, anybody?
JVD.
JVE. Right.
All right, so you got those three, Vex triads, right?
Yeah.
So we can check for our cardiac tamponade. How do we treat that?
Pericardiocentesis.
Pericardiocentesis, I watched one.
In the ER?
Yeah, well, in the cath office.
Pretty sweet, right? Did they probably, I don't know, did they use the same technique that we would use with a 45-degree angle with a needle?
Nope,
Or did they use a crazy different cool technique?
because we wouldn't use the technique.
I think they did basically the same thing.
45-degree angle, the big old
Yeah,
needle?
I was hard, I had to stand
Electro-
behind the,
Yeah, they probably didn't want you in there messing while they're sticking the
Yeah.
needles in me,
so
sorry.
I couldn't see super well, but.
Okay. Right, so pericardial centesis is the way to fix this, right? We don't do it, But it's a recognition and being able to pass off, hey, we've got Beck's triad. The best part would be if you guys rolled in and be like, hey, we got a patient, we've got Beck's triad, and the nurse is gonna look at you like, what the hell is Beck's triad? Are they gonna say what's Beck's triad?
No.
No, they're gonna wait till you walk out of the room and be like, hey, do you guys know what Beck's triad is?
She's got a computer right there, she's Googling.
Yeah,
every time.
you're right, because
Not
they don't
charting
even make
anything.
eye contact with you. So, I've actually, in one of my reports, as we came in, like, I knew that the nurse wasn't saying anything like that, like, wasn't listening at all, and I had like a dementia, Alzheimer's person that was totally just kinda out of it. And so I could tell she wasn't listening to any of my report, and so I'm like, yep, I was like, and then the Oregon Ducks scored a 55-yard touchdown run against the Beavers. The Beavers were pretty much the worst team I've ever seen, and I just started going off on this big football thing. I'm like, yeah, and then the Super Bowl, and da-da-da-da. I'm like, and then I ended it, I was like, all right, you got any questions? She's like, no, sounds good, sounds good. I'm like, all right, yeah, cool. I'm like, hey, what was the score of the game? And she's like, what? I was like, I just talked to you for like 2 minutes about football. I was like, I appreciate your time. I turned around and walked out. I was like, I'm a little passive aggressive when it comes to that kind of thing. Same kind of thing like when people call me on the radio when I'm giving my radio report.
I'm on the phone at the same time.
And they're like, hey, what's the blood sugar? I'm like, blood sugar of this person that it was a head-on MBA and yada yada yada. I'm like,
Who knows?
they're really good at that. I'm like, so the way I end every report, I never ask for questions or answers, or questions or orders. I always end it with, so I always give my ETA at the beginning. I'm like, hey, yeah, we're en route, 5-minute ETA, this is our thing, blah, 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 blah. And I'm just like, yep, if you got no questions, we'll see you in 5. Click. Don't even give me the opportunity to ask me questions. It's like, I'm out, peace, see ya. All right, so, is this person gonna get RSI?
Everybody calls me an asshole.
Oh, man, like, it was bad enough. So I had, oh man, yesterday was a really rough day for me. I had a lot of bad stuff. Well, it wasn't bad. I think this whole caffeine thing might be jacking with my head a little bit because I was short-tempered yesterday. My probie did a bunch of stuff, and finally I'm just like, the other captain, we're a perfect match. Because the other day I talked him off the ledge, he talked me off the edge yesterday, and I'm just like, I was getting ready to chew this probie out for some stuff. Because we've told him multiple times. And I'm just like, yep, really wound up. I'm like, hey, I'm gonna call him in, we're gonna have to talk. He's like, hey, I don't think we should do that. I'm like, what? I'm just like, you're the junior captain, I'm the senior captain. I'm like, so why do you think it's a bad idea? He's like, hey, remember last week? I'm like, yeah. He's like, yeah, our roles have now flip-flopped. I'm like, all right, I'll wait till the next shift. But yeah, so like, I don't even know where I'm going with that. But anyways, back to this, RSI. We're gonna RSI this meds. Oh yeah, because I'm a jerk, that's right. Like my crew, like even my chief said, you all right? That's what it was. Yeah, the whole jerk thing. I'm just like, no, I'm good. I'm good. I had my hat on, pulled real low all day. I just didn't even want to be addressed. Just leave it alone. Right? It's a student captain, I know it is. All right, RSI, what meds are we using on this RSI? Ooh. Oh,
no,
here we go! Hans, what do you got?
Are we going the hyperkalemic?
You tell me, you're the paramedic. Yahtzee! This is where things you guys thought you were gonna skate through. I'm waiting still, Mons, just so you know. Patient dying in front of you.
We are going to use it to polarize.
Hurry up, dude,
and
faster.
schooling.
Faster, what are you gonna do? Faster, 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 faster. Faster, 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 faster.
Which patient are they?
Dude,
I'm asking which one are
Drugs.
they?
Drugs, not doses, it's drugs.
this guy right here.
It's drugs.
This guy and this guy, this guy and this guy, this guy, this guy.
Okay.
Wait, can we see
Lidocaine,
the files?
fentanyl for ICP.
Dominate.
Why not? No, ketamine.
No.
Ketamine
Mons,
is
you're killing me right
hypo-
now, man.
hypertensive.
Actually, I take that back. You're not killing me.
I'm killing him.
You're killing Roger here.
Hypotensive
Then
ketamine.
etomidate.
No,
Sucks.
ketamine.
They could be right.
No, only go succinylcholine. And yeah.
Like I checked out a little while ago. So what do you got?
I said I would do treat for ICP with lidocaine, fentanyl. And go etomidate.
Let's back up a little. So you're going with ICP?
Mhm.
Is this person head injured? Mons, you're in charge, dude. You're the
Yes,
paramedic.
I would think so, because there's
Why?
like with the traumatic asphyxia, there's blood pooling in the brain as well, so you're having increased intracranial pressure with it.
So, good. You're
Yes.
reasoning through your thought process. So
Yes.
that's exactly what you gotta do, right?
So I'm going with
You
lidocaine.
got blood
fentanyl.
vessels in your brain, right?
Yes.
You have now burst everything from here up, right?
Mhm.
So you have those blood vessels, not only in the face, but in the brain that have now burst, right?
Yep.
That blood had nowhere to go, right?
Yep.
Which is gonna cause,
ICP.
there you go, see?
Good job.
Nice job.
Trying to trick me, but
I'm not trying to trick you. What I want you to do is I want you to understand why you
went there.
make the choice. Instead of like, yeah, it looks like there's trauma here, right? But think about why you're doing it, right?
yeah. The only question, because I was thinking either the depolarizing or non-depolarizing for hyperkalemia, go succinylcholine. Depends on how long he's down, maybe too. Would be a question to figure out.
1 hour.
1 hour.
1 hour. You already gave bicarb.
I would just go succinylcholine.
What about ketamine because of hypertensive?
What's ketamine gonna do to your ICP?
Make it worse. Or increase.
Oh,
for
man.
hypotension.
The best part about this is one of those paramedic decision-making things. Because, yes, this person's hypertensive, right? Oh, I
Wait,
love
why
that.
do you care about RSI when he's back worked out? Can't you
He's
just
awake. He's
intubate?
got a GCS of 8.
Yeah, I'm gonna have to definitely put
You
him on.
can't just stick a tube in somebody that's
Yeah.
GCS 8.
Yeah,
I mean, I've intubated people with like a GCS of like 5, 6, and sometimes it's successful, sometimes it's not. And sometimes they're like, oh, as you're trying to, and it's like, yeah, you know, probably my bad, probably should have gave you something, right?
My bad, my
My
bad.
bad, my bad. And so, with the GCS 8, you're definitely gonna have to RSI this person. So, Mons, back to you, my friend.
Dun, dun, dun.
So for either ketamine or etomidate, if I'm already saying it's ICP, then I shouldn't go. I should go with ketamine.
So here's.
Or sorry,
Here's the other
Dominate.
part. So how does ICP present?
so you have
Patients try it.
increased blood pressure,
Okay, what's our blood pressure?
low,
Okay,
Oh,
and low heart rate.
okay.
but we're
That's
reasoning
Do
in.
we have that?
No, we don't.
Oh, son of a. Man, this is getting fun.
Oh,
The good thing is you're the only paramedic on the call. You have 23 EMT basics that have no idea what's going on around you.
that's great.
Are you enjoying this right now?
Yeah.
So I'm not gonna tell you what the right answer is here, okay? Because there's no real right answer for what you choose on this. There's so much going on right here that all you have to do is like, because I just ran you, because you're like, oh, you're trying to trick me with the whole ICP thing, right?
Yeah.
Did I trick you?
No.
Did
Yeah.
I? Yes.
Well,
Yeah.
I questioned myself, like, no, it's,
Because the vitals don't match.
So yeah, so exactly that, right? So yes, you have burst blood vessels all up in here, right?
yeah,
But is it presenting like ICP?
no,
It's not, right?
it's not Cushing's triad.
So we don't have Cushing's triad. Huh, okay.
So
We're
do you
now
treat for
hypotensive.
ICP or not?
Person's dying. Oh geez. I don't even know. I can't even make a decision right now.
I would go ICP because the blood pressure. Well, one thing is that you can see in the head that there's blown blood vessels in the head, so I still lean towards ICP. Still give my
All right,
King fentanyl.
so, how many people are going ICP? How many people are not going ICP?
What's the harm in pushing lidocaine and fentanyl?
So do we remember what lidocaine and fentanyl will basically do?
That's what my
Drop the
question
blood
was.
pressure, and the blood pressure's already low.
No, it doesn't really drop the blood pressure. Basically, it's a pain
Right.
threshold. Yeah, you're controlling like the pain of the intubation is the idea behind those two.
So they don't.
So that they don't bear down, which increases the
So it wouldn't hurt.
A GCS of 8, I'm not worried about that.
Right. So, for me, I'm gonna give the lidocaine, I'm gonna give the fentanyl, right? I'm giving those two drugs. Is everybody okay going there?
But you don't,
Wait, can we go over that one more time though?
Just the pain reflex.
The pre-medication
Pre-medication.
is only for pain.
For lidocaine
The
and
lidocaine
fentanyl.
I
and fentanyl,
understand
Okay.
okay?
that. I know which medications they are,
Good.
and it's because of bearing down, because they have
So,
pain
so,
and then
so,
they
so when
bear
people
down.
have pain, when you start sticking metal objects around your trachea,
Uh-huh,
right, and trying to pass tubes,
yes.
right, you get your vagus response, your gag reflex, and causes you to bear down,
Uh-huh,
right?
which,
When you bear down, causes an increased ICP, right?
Okay.
So that's why when people puke and vomit a whole bunch, they end up with petechiae in their eyes.
Mhm.
And so you know they've had a really rough New Year's Eve when their eyes are bloodshot the next day, for multiple reasons, right? But when it legitimately breaks the blood vessels, And they're like, yeah, I was puking all night. I'm like, yeah, I can see that, right?
Uh-huh.
So you get that increased intracranial pressure based on that, right? So it really doesn't do a lot of damage to give it when you're like on that edge. You're like, well, it's not gonna harm anything. It's not gonna cause anything to really become worse, right? So why do we not give it, so just to take a little side trip real quick, so why do we not give it all the time?
Because it takes a
Takes
minute.
longer.
Because it takes time. So it takes time. For somebody that we don't have to worry about consequences of increasing the ICP, because we're going to give the Versed and the fentanyl afterwards, right? So they're not gonna remember any of it. So we give it at the beginning to not cause the ICP, which would make things worse for the patient. If they don't need it, they don't have the ICP, it's not gonna cause any harm to increase their ICP.
Got it.
Does
So
that make
why
sense?
do if you have a patient with a 1 hour downtime with a GCS of 8, why are you worried about lidocaine and fentanyl anyway? If you're worried about time, why can't you just go straight to ketamine at that point?
Because,
Just bypass
so that's where the idea of, are we worried about the intracranial pressure, right?
Yeah, but
So-
we're just making statements that,
I know where you're going with this.
okay.
Okay, so, to speed things up, because you want that airway, right? So we are on the fence right now of whether or not this person
We care or not.
is the ICP or is not, right? By the time you get everything drawn up, you guys are gonna be so awesome that the whole 3 to 5 minutes for the lidocaine, it's gonna take you 3 minutes to get all your stuff prepped, right? So as you give your sodium bicarb, I'm thinking in my head, I'll just go ahead and give my lidocaine, knowing this is my plan,
Okay, I see
right?
what you're
So you're getting that stuff, so once again, you're thinking, and you're ahead of everything, and you're just like, boom, 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 I'm planning for this, right? So that's where you walk up, hey, I need an occlusive dressing, go get that for me, because you know things are going to take time. And so a little bit of the organizational skills are what you're really working on, okay? So, really quick, we've got like 3 minutes left to finish up what drugs are going here, okay? In your thought process.
So we're past the ICP, went Tomidate, and then I chose succinylcholine for my paralytic.
Okay, so let's go back to etomidate versus ketamine. When do we give ketamine?
For hypo,
Hypotensive.
Hypertensive, respiratory distress, disease, or
Okay,
so,
this is pediatric.
no,
Is this a respiratory disease process?
no.
maybe the guy on the right.
Maybe, yeah, true. But it's not the underlying,
Right.
Cause.
yeah.
Cause.
It's not
So,
super-
But he is a
so which
hypotensive.
one, so, what one did you finally decide to go with?
I said Tomidate,
The Tom, okay.
and then I would,
Blood pressure.
And then I started talking, and now you're
It's like-
reevaluating your
well,
whole.
so
your-
then ketamine's
so,
a whole,
let's say child learns to walk, like your whole maybe this isn't for me, reevaluating, is that what you're doing right now?
no, it's just like,
Good,
how do I think through this? Like,
right,
what's the
good.
steps?
And that's what you gotta do, right? So hypotensive, right, so I'm gonna go with ketamine, okay? Because I'm not suspecting ICP, because we have to perfuse this person,
Mhm.
right? So we legitimately actually need a blood pressure that's going to perfuse the rest of the body,
Yeah.
right? With that being said, I'm having this in my own head of which route am I gonna go and why do I need to do it, right?
Do we,
Yes.
do we push fluids? Do we try and get fluids going, before? I don't wanna get fluids going yet because, well, we don't have circulation, because they're still crushed. But if I start pushing fluids soon, I'm gonna cause more problems up above, so I need to have circulation going first. I know my pressure's gonna tank because all that stuff's going in the system, but I need to get fluids going at some point because my blood pressure's down, and I need to get my blood pressure to stay in my 80s range.
So part of the crush injury protocol is you're starting 2-liter bags and you're running them wide open, right?
Before, okay.
So you're giving them 500 fluid challenges,
Yeah.
one right after the other, right? So part of that crushing, so part of that bicarb, crush
Immediately after
injury,
release of
you are
crush.
dumping
Dump
fluid to them,
Okay.
right? So you're giving your bicarb, you're dumping fluid to them. Sometimes you even go without a little bit of albuterol that we'll talk about a little bit later. So you're dumping this fluid to them, right? You're trying to dilute that acidosis. And so it may be where you dump your fluid and you fix the problem that you're having to think about, right? You bring your pressure up enough to be like, oh, hey, with a little bit of fluid, oh, now I can go etomidate. Boom, okay? Because now I'm not hypotensive because I gave some fluid, because that's what I need to do. I need to dilute, and now I'm to that point where I'm just like, okay, oh, now I'm back to etomidate again, right? And so that's all part of your thought process, building up to it, is being prepared for what you're hoping to obtain, right? You're like, okay, I'm doing fluid, this is what I hope to get from it, okay. 5 or 10,
5.
right? So you're always evaluating, always rechecking, always rechecking. This person, I was just gonna say, this person, I may just have the, hey, Noah,
Blood pressure,
your
blood
job.
pressure.
One blood pressure after another, after another, after another, because I need to keep track of this, because I got a lot of decisions I'm making here in the next 2 to 3 minutes of what's happening. No, you can't push the button. I need a manual blood pressure, because I need to know legit what it is, okay? All right, so now,
I chose succinylcholine, but I have 4 lead on to check for peak T waves.
right, so basically just keeping an eye on it, making sure your patient hasn't become hyperkalemic. Go with your paralysis, because it's short-term paralysis, so the neurologist can then
Switch to
assess
rock.
afterwards. Post-sedation drugs,
Sentinel.
Or 7.
how much percent?
6. I had 6.
You can get 6. You can get 6. And finishing up with your fentanyl.
Whatever way it is.
Yep, whatever you need. Okay?
But you
Everybody
could-
feel totally confident being able to RSI that person?
would you have used succinylcholine to start as well?
Yes, I'd use sucks to start. Unless he presented with some sort of signs of the hyperkalemia. Something that was leading me down that route.
More
And that's
obvious.
just your peak T waves?
Well, you're not to that point yet, right? And so you're making your decisions based on the information that you have.
I'm just looking at that patient right there thinking, holy cow, we're gonna be an hour into this already. And I would probably just,
Assume he's gonna become hyperkalemic. Yeah, you can assume all you want, but until you really start to have presentations, like, you're just not there. And so that's where you have to fall back to your protocol where you're like, hey, I think this person is gonna be hyperkalemic, but they're not, but I'm going on the assumption that this is going to happen, and then you start kind of deviating a little bit from policies and protocols when you start going that route. When you start like guessing and saying, yeah, in 20 minutes this person's gonna be in VFib again, I'm gonna go ahead and start some amiodarone. You just start, like, you just don't know, like.
I'm just thinking of sequence events in the back of the bus when you're.
Be ready to.
You have to
Being-
put on
being
monitor.
ready.
I'm like, you got them on a monitor, you've got all the IV stuff started, you've already put sodium and lidocaine at this point, you're preparing for RSI. At what point, I mean, you're at that sucks rock stage, which one are you gonna go with? And I hope that your monitor is already hooked up. at this point.
I would hope so too.
But if it's not, are you err on the side of rock because of the presentation of your patient right here, knowing that that patient's gonna be probably,
Hyperkalemic.
hyperkalemic?
So going back to the, how we were talking about the thinking, being that thinking person, which is exactly what you're doing. You just can't get into that process of maybe they are, maybe, like until they start to present, until they get their body there, you don't wanna start messing with imbalances prior to it, right? So I would go with sucks, just in the preparation of, okay, because I want to do this now, and then if for some reason something presented itself prior to me giving the sucks, then I start to move in the hyperkalemia
Can I ask
approach.
a question about hyperkalemia? So if the idea is that they're tourniqueted right here, so this is like, because of their crushed, like they have something on top of them.
Okay.
That's what I mean,
Yep,
it's like,
yep, yep, I
there's
thought you were
no-
like, I'm like, no, I was kidding about like actually putting the tourniquet around
No,
the neck.
no, I mean, as in,
Nancy back
it's
here.
cut off, so the blood is just up here. If you're looking for peak T waves on an EKG, like, wouldn't that show what's in the rest of your circulatory and not what's up here? So like, what if this is all like, there's a lot of potassium, and then once you take it off, then it's all together?
So you are not doing, like, you will not get your hyperkalemia while this person is still entrapped. Your hyperkalemia will develop once this person is released
Yeah,
and the circulation returns.
yeah. wouldn't you treat with rock, knowing that that you don't have the evidence, but
You don't have the
basically
evidence.
what he's
Yeah,
saying,
you
like,
don't have the
knowing that
evidence
that's
yet.
gonna.
Yeah, you do not have the evidence that this person has become hyperkalemic yet.
What other contraindications do you have for rocks? So
Time.
there aren't any other reasons.
Right, MD, so basically, if you're not to that point where you are giving it for the hyperkalemia, so yes, you're suspecting hyperkalemia, but you don't have hyperkalemia,
Yeah.
then it automatically becomes an MD order then. Like you have to, so then your time comes back into it, be like,
So that's your waste right there.
that's my decision matrix of,
Okay.
okay, hey,
That makes a lot
I'm
of sense.
suspecting eventually this person's gonna be in hyperkalemia, they're not there yet.
I'm not gonna spend the time phoning the doc.
Exactly,
Okay.
yeah.
That makes
And so that's where I'm gonna go with sucks, knowing they're probably gonna end up in hyperkalemia. Like they're probably gonna get themselves there. But I can't justify on my chart saying they're there because I have nothing other than a little bit of history and anatomy, and I'm pretty sure this is what's going to happen, to be able to justify, to be able to document that.
That makes sense.
And so you have to err on the side of what you have at the time in preparation for it.
I forgot about the MD order part, like, well, if you're, I get it.
Yeah. And documentation. The other thing is documentation. You don't have the hyperkalemia yet, and being able to put in your chart why you chose your route, kind of thing, so. All right. Good job, Hans. Way to work through that.